All right, so let's see if this will work. So the next thing we're going to talk about is using our electrical therapies for muscle contraction. That's now the goal. What's the other E-stim that we've already talked about where our goal was muscle contraction? TENS, but which setting? The opiate liberation. So for that one, we were hoping for like a twitch type of contraction. Now we want a full-blown contraction, full-blown tetanic contraction, something to either for muscle facilitation or strengthening. You guys that are in the clinics, have you guys seen electrotherapy for strengthening? Not so much. Yes, decent amount. I think the one difference between your facility and what they're working at is you're going to see a lot more post-op than what they're seeing a lot of everything. So I think that's probably why you see it more. Definitely something we see more post-op than just off the street. So neuromuscular electrical stimulation, use of electrical stimulation to activate muscle contraction through stimulation of an at least partially intact peripheral nerve. Different from functional neuromuscular stimulation and functional electrical stimulation. These are when there's some sort of electrodes inside of an orthotic to facilitate muscle contraction. So this one here is the ankle dorsiflexion one, where it's just assisting that person. So instead of wearing an AFO, they could have this one, and then the orthotic has electrodes in it that'll fire those anterior tibs as the person's walking. So it's an AFO replacement. What do you guys think about that? Pretty cool. You got anybody ever try to wear an AFO for a little bit? I know I used to. Pretty uncomfortable. You've never heard of an AFO? Really? Ankle foot orthosis? Really? Well. Oh, the internet doesn't work. We can't. Yeah, the internet's not on. All right. In a minute, I'll show you. Yeah. So an AFO for somebody is for somebody who has foot drop. So here's what an AFO is. They insert into the shoe, and it just holds the foot in place for someone who has foot drop. And what's the big problem with somebody with foot drop? We're going to trip over something. So this is the anti-tripping brace. Now, the problem is they're pretty uncomfortable. How you guys ever try to walk around on plastic? Yeah, not great, not fun. They have to fit into the shoes. So now your footwear options are limited. And especially for you fashion people like Tyler or a lot of the women that I treat, that's a huge problem for them, right? So the limited footwear. So the option would be this orthotic with electrical current. What do you think the downside of these FES type devices are? I would imagine you probably can't go in water with it. Yeah. So there's one. Yep. Yeah. So how long do they last for in a day? If you're going to go walk around at, an amusement park for 6 hours, is this going to last 6 hours? Yeah. Yeah. Yep. Another fashion thing too, right? I mean, if Yeah, that's another thing. And that actually, cosmetics is something we shouldn't just discount for our patients. Our patients don't want to walk with canes because they don't want to look old. They don't want to walk with braces, and so this is part of it. Does this fit under clothing or not? And now it also limits what clothing, just like the AFO would for shoes, for footwear. Yeah. Yep, could be. And then there's one other, the big thing. What do we learn about the guy with the burns? The risk of burns, right? So we still, if they're going to be walking around with this all day long, there's going to be risk of those electrotherapy injuries. So anyway, so requires at least a partially intact peripheral nerve because we're going to be adding the electrical current through that nerve and asking the muscle contract because of it. Partial denervation of the nerve because of neuropathy, diabetes, Guillain-Barré might not be possible to stimulate the contraction any more than the patient can do voluntarily. So we just have to look at the effectiveness of it. We could ask for our medical professionals, primary care docs, to then go start this process on, can you do different testing to figure out if these nerves are intact or not? Some of those tests, nerve conduction velocities, EMG evaluations, we could do it. I think for the most part, we can do it. Try it. Most things we do, we try it and see if it works, right? So that we could ask our clinicians to help us out. Contraindications, pacemakers, pregnancy in the third trimester, because we are creating a muscle contraction. So if we create a muscle contraction, we could be inducing labor. So try not to do that. Yep. I would also not do this in the first trimester. I don't do anything in the first trimester. Nope. And skin lesions at the electroplacement sites, that's obvious. Precautions, history of cardiac disorders, monitoring heart rate and blood pressure, just like with any muscle contraction we do, whether it's exercise or even manual muscle testing. If you have cardiac or high blood pressure problems, well, we're going to be doing muscle contractions, so we want to make sure the cardiac system is safe. Superficial metal would be a precaution. Orthopedic implants are okay. They're safe. They're deeper. Some of this more superficial ORIF type stuff might not be. So you had pins in your hand? No, that's right. You avoided surgery. So that if we had pins in our hands, maybe distal radius fracture, we have history of pins in there. That's where I would start going, I don't think I'm going to do that. But knee replacement, hip replacements, no problem. And actually, we do it often after knee replacements, right? Is that when you see it, or mostly ACLs? That's the number. ACL is the number one that I've seen use it for. Yeah. Right. I actually, we'll get into this later. I knew one clinician that would do this type after knee replacement for everybody. Yeah. So impaired sensation is something that was also, for all of our reasons already, precaution. So this is an uncomfortable contraction. One, it's uncomfortable because it's a lot of electrical current. Two, it's uncomfortable because we're trying to create a maximal muscle contraction. Three, that maximal muscle contraction is probably attached to a painful site, like post-surgical knee replacements or post-surgical ACL repairs. Those are the two most common ones that I see that we need to use it for. So patient comfort is something that we are going to have to balance, and we have to educate our patient. This is uncomfortable, and they got to be okay with that. And then also we want a quality muscle contraction. We'll look at the balance between those two things in a little bit. So, yep. The muscle's not firing. Muscle's not firing. We need muscle strengthening for some reason. Yep. So the first thing we can do is use the largest electrodes available to us. That is the first thing we can do to improve the comfort of our patients. Other things that we've already just talked about: clean your electrodes, make sure we have adequate contact, strapping at this point with our pads is probably necessary. Clean the skin, removal of body hair, any of those things. I said it already, but proper education is crucial. We want the muscle to contract. That's what we want out of this. You're going to feel a tingling sensation as we ratchet this current up. But then there's going to be a grabbing sensation of that muscle contraction. And what we want our patient to do when you feel that, we want to have a co-contraction with it. We want you to contract with this electrical current. Most of the time we get our effect after 1 to 2 sessions if the muscle facilitation is used. It could be as long as 6 weeks for muscle strengthening programs for it. Now, I don't see a lot of muscle strengthening protocols for it. It's mostly for this facilitation. 1 to 2 visits, maybe a couple more. Yeah. So the patients that this is probably would be a good indicator for, what manual muscle score do you think? 0 would be the one. Yeah. And as long as that 0 is not because of a complete peripheral nerve injury or spinal cord injury, then this would make sense. Most of the time we see this after surgery. ACL repair is the number one that I see. Could be any surgery though. And there's just this like shock that the body's in, where there's just that interruption of that neuromuscular signal, where you ask the patient contract their muscle and they're saying, I'm trying, and it just won't go. So there's other ways we could try to facilitate that. There's some slapping techniques in the muscle belly to try to improve, to wake up that muscle. All we're doing is increasing that proprioceptive input. So there's some other manual techniques that we could use for it. Usually when a patient's at a 0 post-op, slap these on, do it for a couple visits, then that muscle's woken up and we're okay again. Yeah, and then we stop as soon as they can produce a voluntary contraction on their own without doing this. So waveforms, no clear choice. Symmetrical biphasic, asymmetrical biphasic. There's not a clear choice. I'm going to show you 2 different forms that I'm going to use. The frequency, higher frequency for technic contractions, 100 pulse per second versus 30 seconds. We'll look at some of those parameters in just a little bit. So the quality of contraction is going to be because of the amplitude, how much stimulus we give them, the pulse duration, the frequency, and the duty cycle. We want to gradually increase when introducing to the patient. Typically, the patient will be comfortable within the first 15 minutes when gradually introduced. This is definitely something, because of the accommodation, it's going to be really uncomfortable initially, but then the discomfort should wear off a little bit while it's still effective for the strengthening. So that's another good thing that we can tell our patient. Just like with C-band, right? Hey, initially this kind of sucks. After a few minutes, it'll be okay. It won't be great, but it'll be okay. So that is something we can tell our patients. We want as much stimulus as a patient can withstand with producing a quality contraction. Once we see a quality contraction, we see all of the fibers are contracting, we don't need it up anymore. Some of us, how many of us in here does a good job with these electrical currents, doesn't get bothered by it? I know we have some people that hate even the idea of it. So you guys, we might ratchet this thing all the way up, and just because we're on the perfect motor point, we have decreased impedance, you might feel like, no, I feel the contraction. It doesn't bother me though. Once we as the clinicians see that all of the muscle fibers are firing, we don't need to keep ratcheting it up. That's the goal. All the muscle fibers firing. And I think if we were to use maybe our 10s, we would see like, oh, it's initially just like a couple of fibers, but then as we ratchet up, it's a couple more. Do you guys remember that with your 10s? So that's basically what this is going to be like. We'll start turning up the dial. Patient says, oh, I'm feeling tingling. Turn it up a little bit more. We'll see some fibers contracting. Keep on turning it up even more and more. So our goal is 100% of the muscle fibers contracting. That's how much stimulus we want to add. That's how the dial we want to keep going until then, with some consideration on patient comfort, because it can be uncomfortable. There's some home units for this stuff too. I don't have a home unit here, I don't think. I can't imagine. I guess there's some patients I could imagine doing it for, but man, they are, oh, down the road, there's a great PT. You go over there. Again, so this last line is just what I talked about. We are going to look at the muscle contraction versus our patient comfort. We're going to ask our patient to tolerate the discomfort because we want the maximum contraction of this muscle. And you know what? Our patient might say, this is too much. There's going to be people in here that say, I'm not doing this anymore. And that is okay. Like we should be able to stop. We can't just say, here's a bullet to bite on and keep going. So yeah, and increased adipose tissue might block that stimulation to reach the nerve. We talked about that as we started our electrical current talks. So some people it just won't work for. Our pulse duration, short duration, more amplitude. Our pulse duration is going to be between our pulse duration is going to be between 200 and 400 milliseconds. Lower, we have too much stimulus. Should be between 50 and 40 amps to elicit the proper motor response. We'll look at some of those parameters in a little bit. Pulse rate. For a technic contraction, we are going to occur at frequencies as low as 12 pulses per second, but we're going to be using between 30 and 50 pulses per second. Now, the big thing that we're going to be using this for is for muscle facilitation, right? After surgery, there's that muscle just won't, we're staring at the quad and asking it to contract and it's not moving. It's really fascinating to see. I hope during your clinicals you get to see it, because isn't it wacky where you go like, come on, get going. And there's, I'm trying, not working. There is a scenario where if the patient has that chronic muscle spasm that won't let up. Remember that in the pain cycle where that muscle contraction creates a whole nother host of problems. So this chronic muscle contraction, muscle spasm won't let up. We could potentially use some of these settings to fatigue the muscle, right? Oh, geez, you think you're contracting a little bit now. Here you go. Here's a bunch of stimulus. We'll get maximum contraction out of you. We're going to do it for so much until you fatigue. And guess what? When a muscle fatigues, what's it do? It's got to stop contracting. So there is a thought process where we could use that. What do you guys think of our patients? They're not going to like that, right? It seems pretty aggressive. I would put this in your back pocket though, because how many ways have we already thought about breaking up that muscle contraction and breaking up the pain cycle that's part of that? How many other ways have we already talked about? TENS could do it. IFC. Sure, any of the pain blocking things might help. What other ways? Maybe ultrasound. Anything else? Heat, great idea. Great idea. Yeah. And something we haven't talked about yet, but we will, massage. Just a simple massage. Something that you guys won't be able to do, but you could talk to your team about it. Dry needling could be it, right? So, I mean, yeah, we've got a lot of other options for it. For me, I've got to go pretty far down the list of trying things before I go, well, we're going to put these electrodes on, fatigue the hell out of this muscle until it quits. Like we're going to beat this muscle into submission. Yeah. Pretty far down on the list, but you know what? There's going to be one patient in the next 5 to 10 years of yours that you're not going to know what to do. And you're going to have to go deep into your brain and say, I remember, like maybe we could do it this way. It's unusual. I think there's other ways to target it initially. Massage is always better than this stuff, right? We'd start there, but it is something for you. That just happened here. Look at all of this spotlight. Oh, golly, what did we just do? All right, on time and off time. So we want how much time is the muscle contracting versus how much time we're going to give it to recover. The less rest, the more fatigue. So what's the goal of the treatment? If we want muscle facilitation and muscle strengthening, we want to balance our rest times. If we want more of that like we were just talking about, beat the muscle into submission, we could go less. So majority of our protocols have a 1-to-3 ratio or a 1-to-5 ratio. So 4 seconds on, 12 seconds off, 10 seconds on, 50 seconds off, something along those lines. On time, how much time do we want the contraction for? Between 2 and 10 seconds. I aim for 10 seconds. That's my goal. Contractions of 8 to 12 seconds are typically comfortable. We're getting as much force as we need. We're restoring that brain-body connection. The shorter the duration of contraction, I'm a little hesitant on that. But for our patients who really experience a lot of discomfort, maybe the shorter the contraction, the shorter the on time, maybe that's something we need to balance for our patients. Ramp time is how much time we're going to take for our stimulus to go from 0 to its peak. So in general, we want a 2-second ramp time. That's really comfortable. It's going to slowly ratchet up. We don't really want this to be an on and off switch. Nothing, nothing, nothing. Maximal contraction, nothing, nothing, nothing. Maximal contraction, right? Having that gradual ramp up is more comfortable for our patients. For our strengthening programs, we want to have our patient co-contract with the E-stim. Our overload principle, small number of high intensity contractions, at least 70% of maximal voluntary contractions, 3 to 10 sessions per week, 3 to 5 sessions per week. It is superior than exercise alone for those people with orthopedic injuries, questionable with non-injured people. So a lot of this research for strengthening with NMES actually came out of Russia when they were dominating the Olympics in the Soviet era. So Mary's happiness. That's right. We were there. Yeah. Yep. Now, I did tell you, I know one therapist that for all of her total knees, she uses NMES. This is the protocol that she uses. It's great. Her patients get a ton of benefit from it. I don't know if the discomfort is one thing that I really hesitate. But I mean, she showed me videos of her. It was at a conference. She was giving the lecture, and she showed videos of her patients during their treatments, and they're doing a really good job with it, and they were having fun. So yeah, maybe you can. Other potential uses: reducing muscle guarding. If we reduce the muscle guarding, we interrupt the pain cycle. So that would be nice. Talked about that a little bit. Maybe some edema reduction, muscle pumping contraction. So if we stimulate these muscles, contract, relax, maybe that can help some edema and assist in lymphatic drainage. Orthopedic substitution, we talked about a little bit as well. So some considerations: one, the patient's cognitive ability has to be intact for us to use this. They have to understand, what are we doing this for? They have to be able to understand the importance of discomfort versus contraction. They have to be on board with this. Anyway, I got nothing to expand on that. So documentation, what is the goal? Facilitation versus strengthening, I think, is important. The location, exactly what muscles, and if we can be more precise on the exact location, the better. On and off times, treatment time, frequency, ramp time. To measure progress is always important. So whatever we used initially, if we used an MMT, we can redo those MMTs. That's probably the easiest one to use. And the patient's response to treatment is always good to throw on there. So the two modes that we're going to be using this for, Russian, better for larger muscles, and then VMS, variable muscle stimulation, which is a biphasic waveform. There are home and clinical units available on this VMS, but the VMS is better for smaller muscles. Other potential options: IFC, we saw in some settings we could still elicit muscle contractions. TENS, High volt is another one we'll look at later. So here's Russian versus our VMS or our biphasic VMS. Russian better for larger muscles, better for maximal force. Biphasic, theoretically better tolerated than Russian, although we'll see if you guys agree with that or not. Biphasic better for smaller muscles, more versatility. We have a lot more settings with biphasic we can mess around with. Here's our recap. So for our facilitation, what we want is our frequency to be 30 and 40 pulses per second. Pulse duration for either is going to be 200 to 400 milliseconds. Ramp time, I think 2 seconds is the best. You guys feel free to play around with your ramp time, cutting that down, seeing how you feel about it. The duty cycle for facilitation is just long enough to complete a rep. Between 8 and 10 seconds is comfortable for the patient, I think, an adequate time. So that's what I would aim for. Although for our patients who have a lot of trouble with this, a lot of discomfort with it, you might consider cutting that duty cycle down. Say, okay, we're only going to do this for 4 seconds. Maybe that is enough for the patient. Treatment duration between 10 and 30 minutes, likely 1 to 2 sessions. Again, hopefully, if we do this well and the patient responds, hopefully we're only going to have to do this once or twice, maybe a couple of weeks. What's the most amount of time can you remember seeing somebody do this for? Wow. Yep. Yep. Yeah, that's a long time. Anyway, our electrode placement, we're going to have a bipolar setup, so 2 electrodes, definitely trying to get onto motor points. Definitely trying to find those motor points. And then the amplitude, we're going to ratchet this up as high as the patient can tolerate with consideration of the muscle contraction. We want full muscle contraction. There's going to be a point where you keep ratcheting it up and the muscle won't contract anymore. Once you've recruited all fibers, you can stop, regardless of patient comfort. The things we have to figure out is if the patient can't tolerate enough to get up to that level. That'll be the tricky thing. So, yeah. We want both pads on the muscle. And what we'll have to play with is, so the motor points are in general at the muscle belly. If the muscle belly is big enough where we could put both on it, like the quads, we can find areas on the quads for that. If we wanted to be more specific and just say, okay, it's just VMO, the vastus medialis, it might be a little tougher to do that. But trying to get both pads on the muscle we're working on is what we're going to want to do. And that's a little bit of trial and error for each person, and really each session it might take that amount of like finagling. Yeah. Oh, you're getting he'll be able to see it. You'll be able to see it. I'll show you, hopefully. You don't have to shut everything off, but you don't want any current going through the electrodes as you move it. You guys ever, or who are techs, you guys ever pull a pad off when the machine's still on? You go, whoa, that's on. So yeah, or turn the intensity all the way down. Yeah, you only need to make that mistake once. All right, I'll show you with Russian here. So just quickly, just to finish this up too, our strengthening, the patient position is, so for facilitation, sorry, for the patient position, we want starting at mid-range. So again, when is the muscle at its strongest? Mid-range. So if we put the patient in mid-range and then add this electrical current, we're going to hopefully get the patient to be able to contract that muscle at the easiest point. For strengthening, this is where we're going to do our multi-range isometrics. We're going to do this throughout the arc of motion. Our frequency, we're up to 50 pulses per second, same pulse duration, ramp time's the same, 1 to 3 or 1 to 5 ratio on versus off time. And then 10 to 15 contractions, 3 to 5 times a week for 6 weeks. That's the strengthening protocol. I don't see that being used very frequently. Usually this is just a muscle facilitation thing. Post-surgical, patients trying to contract this muscle and it's not. We're just trying to reset that brain-body connection. All right, so we'll see if you can see. All right, so I've got everything set up for Russian. I'm going to start turning this up. All right, so I'm starting to feel a little tingling here, right? That's that tingling, and then it's going to start to grab. All right, you see that little muscle contraction there? All right, is it all of the fibers though? No, I'm not at maximal contraction, right? So if I keep, as I keep turning this up, you see more and more motion. You see more and more of those fibers being recruited. Eventually, I'm going to keep turning this up. Do you guys see any more contraction? No, it just sucks more. All right. So once you, as the clinician, turn this up, but there's no additional fibers being recruited there, you're done. Doesn't matter if the patient says, I can take more. No, we're done. We've done what we need to. And then turns off. 2 seconds ramp up. Then I have to co-contract for 10 seconds. Then I put it to a 1 to 5 ratio. So 10 seconds on, 50 seconds off. That's what I could do something else. Okay. All right. So there's my Russian setting. For these Chattanoogas, there's a couple different biphasic selections we could choose from. The other selections of biphasic are more for pain relief than anything else. That's not what we're using it for. The button you want to press are VMS. Okay, so it's in the middle of the screen on the left-hand column. It brings up 3 different categories for us: VMS, VMS burst, or VMS FR. I forget the VMS versus VMS burst. I'll look into that in a little bit. The VMS FR is if we wanted to have antagonist muscles to contract. So it's 2 channels, and we would set up, okay, first biceps contracts, then immediately when biceps shuts off, the triceps will kick on. So that's pretty cool. I don't know why I would use that, but hey, it's there. Great. So for us, for now, just choose the VMS, edit your parameters, and play around that way. Okay? You would have, for that one, we would have 2 channels, and we'd set up the pads on, 2 pads on the biceps, 2 pads on the antagonist, in this case, the triceps. Yeah. Yeah, and I would add resistance at every 20. Yeah. Yeah. Yeah, during the contraction, because we want to get up to that 70% maximum voluntary contraction, which is a fair amount. Yeah.
But you want to add the strength
I would edit my machine so that I recruit all of the fibers. Okay, now on my 10-second on time, go, 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 go. Okay, 50-second rest time, move up another 20 degrees. Go, 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 go. Yeah. Yeah. Yep. And that's for 10 to 15 seconds. Again, I don't see a lot of use for the strengthening things. I know one clinician that uses it. So, yeah. Start at mid-range, try to elicit, patient co-contracts for everything. Go, go, go. Yeah, we're a good cheerleader. Yeah. Nope. We add resistance. Yeah. Yep.
co-contraction.
When we ask them, it's not just a machine. You are telling your biceps to contract at the same time as the machine's firing your biceps. Yeah, they're adding that force to it. Yep. All right, so I've got some locations I want us to try. For Russian, I want us to try quads, and specifically after the get both quads, but I also want to see if you can get specifically to the VMO. Gastrocs, lumbar, paraspinals. For the biphasic, biceps, tricep, wrist flexors, extensors, anterior tib, peroneal. See if we can get all those areas. Okay, so lots of practice. All right, let's have some fun.